Okay, great. So this is a sponsored symposium by Anteris Technologies, Beyond the Gradient, Restoring Native Flow with TAVR for Enhanced Left Ventricular Recovery. So I'm here with an amazing faculty. To my left, Muhammad Abdul Wahab, you see Yoshi Kaneko, Anita Askar, Amar Krishnaswamy, Brian Lindman, Stefan Windecker, and João Cavalcante. João, you up here too?
Yes.
There you go. Okay, perfect. And we're really today going to be talking about a novel technology. This is the Innovation Theater, so we always like talking about new things and new technologies. Many people think TAVR is just a very mature procedure where there's no innovation left. I'm hoping that by the end of this 1-hour session together, you'll be able to see that maybe, there's a lot more we still need to figure out in TAVR. There's a lot more we can do for our patients to get better outcomes. And maybe even the way we've been thinking about TAVR, we need to start changing. It's all been about just, let's get that valve in without PVL, without vascular complications, without giving the patient a pacemaker. But now that it's mature, we need to start thinking about other things. We need to start thinking about lifetime management, about maybe could we give our patients a valve that'll be similar to the valves they were born with, not just in lasting longer, but in the way it functions and the impact it has on the left ventricle. And those are the kind of topics we're going to be trying to address today. So I think we're going to go straight into it, Yoshi. Let's introduce everybody into this novel technology, and we can build a discussion from there.
Great. Thank you, Azim. So the word biomimetic, I don't know how many of you can pronounce this, but this is the key of this valve. And what does that mean? So this is a great animation of how the valve is made. It's actually made out of one piece of pericardium, which is made into a valve that mimics a healthy valve. So this is the crux of the design of this valve. And you're going to hear that it shows favorable hemodynamic performance on an easy-to-use balloon expandable platform. And you're going to hear a lot about this flow concept, which is very interesting and very different from the other valves. And we believe that this is going to increase the durability of the valve. And the company Anteris was formerly called Admedis, but they were creating pericardium for a long period of time. So it's not a company that just came and made a valve. They were a pericardial valve company. Their valve was approved in 2000. Their pericardium was approved in 2014, and it has been used in patients for a long period of time. And with the same proven tissue, they created this new valve, the DuraVar, which really started the journey back in 2020. This is what the valve looks like. It's, again, the biomimetic valve. It's got anti-calcification treatment with a PVL skirt. The actual frame is cobalt chromium. It is balloon expandable. It's got 3 sizes, small, medium, and large, and you can see that they cover 21 to 29 millimeter annulus. The device, the delivery system is actually very easy to use. Those of you who have used the balloon expandable valve platform, you don't have to load the balloon. It's actually loaded on the valve itself already. It's got flex, and you do adjust with the volume based on the sizing. But the most important factor is that you can actually align the commissure by rotating the knobs. You're going to see it later on. But by rotating the knob, you can actually align it, which is a very important component of lifetime management in the future. This is probably one of the most important slides that I'm going to show. And those of you who actually have seen the valve itself, you will see that the valve opens almost completely compared to the other transcatheter valves. The other transcatheter valves has a suture line. You have to suture the 3 different pieces of pericardium into one valve. The DuraVar does not have that. So for that reason, you can see that it opens up almost at the flexion of the leaflet. Therefore, the EOA and the gradient, EOA becomes very high and the gradient becomes very low. Currently, over 130 patients have been treated with a DurAVR valve. These are some of the clinical studies that have been done, including several EFS, both in US and EU. And the Paradigm pivotal trial has started globally, and you're going to hear about that more. These are some of the publications. This one specifically is on the 30-day outcome on 100 patients, relatively older population of STS prom of 4.7. You can see that the annulus was a bit on the smaller side, with the excellent outcomes: mortality of 0%, no cardiovascular mortality, and only 6% of permanent pacemaker implantation. So the short-term results are excellent at the moment. But not only that, the hemodynamics, you're going to hear more from Anita and Joel about this, but the hemodynamics has been excellent with this study. After implantation at 1 year, the EOA is over 2, which is large for balloon expandable valve, comparable to self-expanding valve, or even better in terms of the gradient. And you can see that the PVL was seen mild in 30%. Only 3% had moderate to severe PPM at 30 days. So that hemodynamic benefit translates into patient prosthesis mismatch being extremely low with this particular device. And Joao will talk extensively about the laminar flow, but even I can understand that the flows are extremely different compared to the aortic stenosis flow and the post-DurAVR flow. It's very laminar, consistent, and parallel flow. So because of all these reasons, we believe that DurAVR is designed for improved durability. Flow is related to long-term durability, and it's got multiple features, including the adapt tissue with anti-calcification treatment. This is the pericardium that this company had really invested a long time. And the biomimetic leaflet shape. You've seen how much it opens compared to some of the other valves. And I personally feel that it's probably because of the lack of that suture line, which makes it completely wide open. And you will see it when you actually take a look at the valve. And most importantly, restoration of the physiologic laminar flow and hemodynamics, which is intentionally designed to address the known causes of failure. So again, new type of valve, very exciting times, and you're going to see a case report and other evidence that supports all these hypotheses. Thank you very much.
Thanks, Yoshi. Thanks for introducing us to the technology. We'll have Amrit now maybe take us through a case and really talk about how do we define and understand TAVR success in 2026. Thanks, Amrit.
Thanks, Azim, and thanks all for attending this session. So I'm just going to provide a case and the course of this patient to try to set up some of the discussion for as this afternoon goes along. So a fairly typical patient, 82 years old with symptomatic and severe aortic valve stenosis. You can see here quite significant mean gradient of 68 millimeters of mercury. The annulus area is about 413 millimeters square. Relatively large sinuses. You can appreciate the severe calcifications of the trileaflet aortic valve. I want to show the commissural alignment technology that Yoshi mentioned. You can see in the fluoro here that these commissural tabs in the back are not entirely aligned. You can see Ola de Bakker here just turning the knob. There's a cine. Again, you can see that they're almost lined up, but not quite exactly. So a little bit more turning of this dial back here. You'll see the commissural tabs come into focus and then on cine to confirm. The deployment of the valve is a relatively typical experience for those of you who are familiar with the balloon expandable platforms. You can see here a very predictable sort of deployment and ultimately a nice valve result with commercial alignment and no aortic valve regurgitation. Yoshi mentioned the single piece of pericardial design. You can see this long leaflet coaptation, which I'm sure Joao will touch on shortly to understand how that also affects flow dynamics in the MRI. So this patient at 30 days experienced no adverse events. I think a few interesting things to notice here. If you look at the 30-day CT, you can see an extremely uniform valve deployment, nearly 22 to 23 millimeters all throughout, which is the expected size of that valve, a relatively circular valve as well, with an ellipticity index that approaches approximately 1. Also, as Yoshi mentioned, quite favorable hemodynamics for this patient, and generally with this valve, a 7.5 millimeter mean gradient with an effective orifice area of about 2.5 centimeters square. So this is a list of things that we've generally come to expect in the current era with TAVR: predictable deployment, commissural alignment with a few of the platforms that are available, low pacemaker rates, and PVL rates. But what else can this patient experience with DurAVR? And this is what we think, and Joao will comment on with more of the data. But we know that generally speaking, signs of cardiac damage, for which there's been a proliferation of data over the last few years, and outcomes that are worse with things like LVH, increasing LV mass, LV remodeling, and so forth, do not always regress or improve after simply replacing the aortic valve. And the question is whether this idea of physiologic laminar flow may be related in part to how we can expect patients to get better after their aortic valve stenosis is fixed. So if you look at this patient's MRI after the TAVI, at 6 months out, you can see that the aortic flow, the index systolic flow reversal ratio, is a marker of physiologic flow. Clearly abnormal here at baseline, and at 6 months out, essentially approaching that of patients without aortic valve stenosis. Along similar lines with the cardiac MRI, you can see that at baseline, 151 grams of LV mass, which regressed by nearly 40% at 6 months. And this was, and if this correlates also then to LV volumes, you see here end diastolic volume declining at 6 months, and then again at 1 year. Similarly, LV end systolic volume, all correlated as well to the LV mass that I mentioned previously. What the patient feels, of course, is their quality of life. And again, for this patient, as we would hope and expect, improvements that were, which continued and were consistent with regard to functional capacity. So ultimately, early results, as Yoshi demonstrated, suggest safety and efficacy of the DurAVR platform, low rates of pacemaker with favorable hemodynamics, and the ability to align the commissures. The confirmation of all of these, of course, pending in the larger pivotal paradigm trial that is started now. It will be interesting to see where future discussion goes surrounding markers of flow and cardiac damage using advanced cardiac imaging, like what I showed you in the cardiac MRI, and we'll hear more about that from Joao shortly. Thank you.
Thanks, Amr.
Okay, so just a quick reminder that you are allowed to ask questions, of course. So we would like to encourage you to just go to the microphones if you have a question or a concern, and we'd be happy to answer this with the panel. In the meantime, maybe before we move forward, we have like a couple of minutes time to discuss among ourselves. I'll maybe start by asking Stefan. I mean, we kept on formulating like a wish list of what can be improved in the currently available TAVR devices, and it appears that this platform has a lot of this, like of these factors on our wish list somehow integrated in. But if you choose one of these additional features or advantages of this platform, what would you say is the most striking thing?
Thank you. I'm curious of what others will say, but for me, the most striking is the hemodynamic profile as it relates to effective orifice area enlargement. Based on, and where this is particularly important is in any setting of small anatomy. And in that regard, also, let's say, valve-in-valve procedures. And the reason is that this is important. I think we all appreciate the let's say, advantages of a short frame valve in terms of future coronary access. But on the limitation side, we always regret, particularly in smaller anatomies, the hemodynamic effect. And this combination, I think, is really a major paradigm shift where you basically combine this balloon expandable feature with what we are more used from a self-expanding valve. Now, why do I think this is more or the most important? I think, first of all, the issues related to PPM and the ability to do valve-in-valve procedures is certainly at a higher level. But I think it may also lend itself for other advantages which we need to prove. But one thing could be long-term durability. So in other words, if you have a very favorable hemodynamic profile with laminar flow, I think you could hypothesize, well, what's the benefit in the long term? And along the same side, I would also say it's appealing in terms of antithrombotic treatment and properties. So, I think what we slowly see, TAVR valves probably have a little bit more thrombosis rate than surgical valves. And so we need to continue to work on this. And I think one, maybe the hemodynamics, the other one would be the antithrombotic therapy. And finally, I think despite, let's say, having this large effective orifice area, your pacemaker rate is not is in the range of what you expect of a balloon expander. So that, in a nutshell, is why I think it's why that features, I think, for me, the most important one.
Yeah, Stefan, absolutely. I think you mentioned also, hemodynamics, particularly when we think about, certain patient subsets becomes particularly important. And, we've been talking a lot in the last couple of years about small annuli and about, hemodynamics and how do we improve the hemodynamics. Really, the prime example of a small annulus that we struggle to treat with balloon expandable valves are valve-in-valves. And Anita, you've actually have real clinical experience trying to use this valve in really small surgical valves, which I would think would be, just the worst case example of trying to use a new balloon expandable valve. But also the best test example. You want to share maybe, some of your experience in treating those kinds of anatomies and how the hemodynamics have come out?
Yeah, so to be fair, when I first heard about Anteris, I'd approached Chris Maduri and I thought the perfect place for this would be valve-in-valve for mitrals. And, we were far away from that. But we ended up with a bunch of cases where we had significant concerns about putting self-expanding because of coronary access, et cetera. And so we started doing valve-in-valve for those patients. And what was surprising to me was the hemodynamic benefit. And so we all accept that when we're going to do a valve-in-valve, we try to aim for a gradient less than 20. Some of the registry data suggested that's associated with an adverse outcome. And so we were prepared for that because most of these were small. And what we had access to early on with Duravar was the small size, the only size that was available. What amazed us in our experience was that in these surgical valves, and these were surgical valves that were all done at our institution, was we found that we were able to replace that with a valve-in-valve and return the patient to the same gradient they had at the time of their initial surgical valve replacement, which was not what we were expecting. And really showed to us, what is the benefit of improved hemodynamics, even in, as you said, the toughest case scenario, which is a valve-in-valve and a small valve-in-valve. And so we're really excited for the Paradigm valve-in-valve registry. And so for those of you who are participating in the trial, we would love for you to enroll. Gaurav Alawati and I are the PIs of this valve-in-valve registry. And we're really excited to see and have more evidence to show us, how can this perform in this really challenging anatomy?
Yeah.
I'm trying to imagine, and this question maybe is for Yoshi. Do we have surgical valves that have similarities from a leaflet perspective to this new technology, or is it something that is not available surgically?
There is a technique called the Ozaki procedure where the surgeons actually cut the leaflets from the pericardium like a cookie cutter and then create it into a bioprosthetic valve. Those valves will have a large coaptation point, and there's some proposed hemodynamic benefit of that particular valve. So if there is something that is similar to that, to this particular valve, that's the only valve that I can think of. None of the existing stented bioprosthesis will be similar to this. So that's why I think this is so exciting.
Yeah. I was also taken aback, Yoshi. I'm going to just stick with you a second.
Yeah.
Because you just, as a surgeon, you just have a different insight to many of us because you've seen valves, surgical valves, as well as, transcatheter valves, and you've removed valves and repaired them. I was struck by the one image that Amr showed, right, which was the TE image of leaflet coaptation.
Yeah.
And there were two things that struck me about it. How, how much coaptation there is, right? And the second one was how widely open the leaflets open. I was looking at it again, and every time I look at it, I'm like taken aback. The leaflets almost look like they touch the side of the wall of the aorta.
Yeah.
I mean, obviously that must be good. They must be contributing to why we're seeing this different type of flow. But have you seen that with other valves?
No, not really. I mean, we all see the transcatheter valves, right?
Yeah.
And they get closer to the stent compared to the surgical valves. The stent that the surgical valves are mounted on, you have to have a cuff for the surgeon to suture. So that's why the internal diameter becomes very, very small. It will be interesting to see what the internal diameter of this valve is, because that ratio to the entire diameter of the valve to the opening, it has to be extremely high compared to other bioprosthesis. And, there are some other valves that, going back to your question, Mohammed, there are some other valves that may potentially mimic, which is the Ross, which is the native valve. And we all know that Rosses are preferred for some of the younger patients because of the durability. So, we're going to have to wait, whether that hypothesis really holds, but it really makes you excited when you see that wide opening from the valve itself.
I mean, another aspect related also to the lifetime management concept is the commercial alignment feature. Maybe this question to you, Amr. We don't have this routinely now with the currently available short frame platforms, at least not in a reliable, reproducible way. Maybe you can explain to the participants why it is not achievable with current platforms and what are the differences now with this device.
Thanks, Mohammed. I think that there's a lot of potential benefits to the commissural alignment. One, which is somewhat conjectural, is simply that by having commissural alignment and the way that our surgeons place the valves, is that it helps to facilitate some of the flow in the sinuses, and to the point that Stefan was making earlier, how that might affect things like leaflet thrombosis and durability and so forth, and this flow. Secondly, of course, and more practically, commissural alignment allows both easier coronary access when knowing you don't have a post in front of the coronary artery, and in the future, a TAV and TAV option, especially for those patients where the frame of the valve may end up slightly above the coronaries in the setting of a small sinus. Having commissural alignment will facilitate the ability to do a leaflet modification procedure. And so I think there are a lot of potential benefits to commissural alignment. We don't really have that technology readily available, as you noted, in the current short frame balloon expandable platforms. But this is a very easy, as you saw Ole do, that entire video was 30 seconds. And so it takes truly even less time to simply look at the commissural posts in an appropriate sort of ariocaudal or cusp overlap projection to then be able to place the commissures on either side of the left main coronary artery.
Yeah, so it's a combination of like visualizing the posts, but also the ability to actively align them with the native commissures, which is something that we don't currently have with the available platforms. So we will be talking about flow in a minute, but before we talk in details, maybe it's a provocative question to Joao. Why are we talking about flow now? Why didn't we pay attention to that?
Why did we decide to go in this?
Yeah.
Well, look, I think Brian and Anita are going to also expand on that. The valve sits in a position that it dialogues with both the ventricle and the arteries. So we have to understand the aortic stenosis is a continuum, just like the flow. It has to come from a place, move through it, and get to a different destination. And when you replace a valve, you have to respect both before, the middle, and above. We have been fixing valves, but I think the scrutiny, as you highlighted, it's higher now. We can place valves and can do that safely. The scrutiny now is how do you deliver that to the best optimized circumstances to that valve to perform in its best. And I think as we start to refine our understanding that, there is a price that you pay for, who doesn't believe that PPM matters? I mean, it matters for surgical valves. Why would it not matter for transcatheter? It's the same disease. It does matter. So if you can deliver that, and I think it's not just a measurement here. I think it matters. So the better you can deliver that in the smaller zip code, be that the smaller annulus, with the single digits, you can achieve a better improvement. Now, how can you optimize even beyond that? Beyond gradients is what we're going to talk next.
Absolutely, John. And I'm going to be asking you about really the validation of this, because I want to know, is it more than just pretty pictures that I get Cavalcante to show me always, or does it actually mean something for patients? But, I think I want to transition. Brian, we're going to transition to you. And part of the discussion is often, when we see patients, we do their TAVR, and on some occasions, I see a patient, I've done their valve, and they come back to me months later, and they're still symptomatic. They still don't feel like they've gotten all the benefit. They're still a bit fatigued. And I've often wondered, Brian, are we thinking too much just about relieving the stenosis? And is there more we should be thinking about?
Yeah, great. Thank you. And as Joe has set up nicely, aortic stenosis, while ostensibly a valve disease, its morbidity and mortality really are a result of how it affects the myocardium. And here you can see there are several aspects to that in terms of hypertrophy, fibrosis, and systolic and diastolic function, dysfunction that have underlying molecular mechanisms that manifest themselves to impact the health of the myocardium. And so when I'm thinking about patients with aortic stenosis, as the aortic valve narrows and as obstruction progresses, there is this response that is variable from patient to patient that manifests in maladaptive remodeling and dysfunction of the ventricle that impacts how the patients do. And this maladaptive remodeling is linked to residual risk related to heart failure. And so patients, so I think AS can be considered a precipitant of and precursor to heart failure. And after the valve is replaced, an effort is directed towards mitigating heart failure after valve replacement. So how might we prevent and mitigate heart failure? We may intervene sooner, before symptoms or before AS is severe. There's medical therapy that might target the valve or the ventricle to maintain its health, and then medical therapy that might augment reverse remodeling in recovery afterwards. And pertinent to our discussion today, perhaps characteristics of the valve and the flow that might augment LV recovery. So these are data just outlining the relevance of LVH. Oftentimes in medical school, we were taught that LVH is compensatory and therefore we think good. And these are data from the PARTNER trial, large number of patients showing that severe LVH prior to valve replacement is associated with worse outcomes after the TAVR is performed. Also data from the PARTNER trial looking at patients with moderate or severe LVH prior to their TAVR procedure, showing that there's substantial variability in the degree to which the LVH regresses after valve replacement. And these data linking the amount of regression after the valve is put in to long-term outcomes, heart outcomes, cardiovascular death or rehospitalization, and that many of these patients, 40% here, who went into the procedure with moderate or severe LVH have severe LVH 1 year after the procedure, and that this is linked to a marked increase in events out to 5 years. These are work from Mark DeWeck and his colleagues in Edinburgh who have taught us a lot about the diffuse and replacement fibrosis that sets in the pressure overloaded ventricle. This starts even earlier stage at moderate aortic stenosis, and the presence of more diffuse fibrosis and replacement fibrosis are also linked to mortality in these patients. And then also something we probably think even less about is the vasculature that João alluded to. And we've shown and others have shown that increased vascular afterload in patients with aortic stenosis is independently associated with increased mortality after the procedure. So in summary, the ventricle and the vasculature contribute meaningfully to clinical outcomes in patients with aortic stenosis. Maladaptive remodeling and dysfunction that develops pre-AVR can sometimes regress and recover to varying extent after AVR, the extent of which is linked to subsequent clinical outcomes. So it's a clinically meaningful surrogate endpoint. And factors that more optimally unload the heart, whether they're medicines or different valve characteristics, may improve myocardial recovery and as a result, improve patient outcomes. Thank you for your attention.
Thanks, Brian. I'm sure we're going to have some questions for you in the discussion part. We'll have Anita talk to us about valve performance and why it's more than just the gradient.
Thank you. So I want you to start thinking about, when we think about valves, we think about a gradient pre-valve replacement, and then we always look at the gradient post-valve replacement. But I think as Brian very elegantly described, it's not just about the valve, it's also about the ventricle. And so I'm going to try to explain to you that it's not just about the valve and it's not just about the gradient. And so if you think about what a normal aortic valve looks like, your native aortic valve, a native healthy valve, has a mean gradient of about 1 to 2 millimeters of mercury, and that's flow going through the valve. But your typical post-TAVR valve has a mean gradient about 8 to 12. And so I think we need to be thinking about the fact that as TAVR becomes a lifetime therapy, valve physiology also matters. And we're learning a lot from MRI, we're learning a lot from new technology, but we can also learn a lot by going back. And if you think, these are some drawings of the aortic valve drawn by Da Vinci between 1506 and 1519. And for those of you who are not aware, he was very interested in human physiology, animal physiology. He did a lot of dissections, and these are collections from his notebooks that were published in an ATS paper several years ago. But he spent a lot of time looking at the aortic valve and trying to understand the aortic valve. And if you look at this middle panel, he's actually drawing the coaptation of the aortic valve in this drawing. And so he was trying very hard to understand, how does the aorta work? How does the aortic valve work? In fact, he's trying to draw the actual currents and the flows inside the sinuses. This is back in the 1500s. And so we're learning a lot of that he already knew probably in the 1500s about normal aortic function, about this central laminar flow, and that the aorta and the system is very energy efficient. And this is what ensures steady perfusion of our peripheral tissues, our coronary arteries, and all the other tissues that are supplied by the aorta. And that vascular health is very important. The afterload, the vascular tone, all these things are very important and are part of the normal aortic function. When we think about native valve physiology, what we like to see is this central laminar flow with minimal resistance. And remember, it's this resistance that results in compensatory left ventricular hypertrophy. And so if you look at this picture on the right, there's 3 panels here. There's the healthy control on top and the stenotic patient on the bottom. And what you can see is if you look at the healthy control, you see that the velocity, there's a peak in the velocity as you go through the valve, but the flow for the most part is relatively similar. There's not a lot of different velocities, but what you also see is minimal energy loss. So you're not losing energy as blood is flowing through the valve. This is an extremely efficient hydraulic structure. What we see, however, is when we start to get disease, that when you have aortic stenosis, you see the velocity increases. And so what's happening after this is we're seeing energy loss. And so we're losing energy as the flow goes through the aortic valve in aortic stenosis. And so normally, nature has designed the aortic valve for minimal energy loss. As the aortic valve gets diseased, what we see is energy loss. And gradient, remember, is a measurement. And what this represents in terms of physiology is actually energy loss through the system. And so what do we see in terms of hemodynamics and work of the LV? Residual valve obstruction actually increases LV wall stress, prevents LV remodeling. You get increased myocardial oxygen demand, increased cardiac work, and again, reduced LV reverse remodeling. So if you look at these pressure volume loops, look at pre-intervention, what you see is this gradient. This is what we measure. And what this corresponds to is increased left ventricular workload. After the intervention, our gradient is greatly improved, but the workload is still significant. It's improved from previous, but it is significant. And so even though we celebrate that we have reduced that mean gradient from 40 down to 20, the ventricle still feels every millimeter of that gradient. And so the gradient alone doesn't define valve performance, and Joao's going to talk about this, laminar flow versus turbulent flow, but just keep in mind that laminar flow represents what nature intended, reduced afterflow, efficient workflow, and that not having laminar flow may impact structural valve deterioration and durability. And when we think about the potential clinical impact of abnormal flow, may influence the aortic conduit, increased inflammation, atherosclerosis, reduced exercise capacity, a lot of these symptoms that patients have despite a valve replacement. So what do we need? We know that TAVR has transformed the treatment of aortic stenosis, but as we're moving towards lifetime valve therapy, we're not thinking just now about valve replacement. Now we're thinking about how can we restore normal valve physiology, and that these new platforms really need to go to the next level, and they need to be designed with this principle in mind. Thank you.
Okay, so Joao, now it's your chance to convince us or to demystify the science of aortic flow.
No, I truly appreciate this partnership with Anteras and the opportunity to speak here on their behalf. A lot of this goes back to also work that we started to have some thoughts about how beneficial those findings that Azim highlighted from the TE could impact. And collaboration with another great friend, Dr. Pankaj Garg, who also has done some beautiful work on the 4D flow, and us translating those findings to all of us. So what does that mean, and what is it telling us? So as you heard before, the DuraVar was designed with the hypothesis that that unique single leaflet would preserve this more physiological flow, would have a nice opening area without the loss of the rheostate from the commissure posts, but also opening with a nice coaptation length as well. And by doing so, hopefully restoring the laminar flow. Now we have to prove that. If you look at on the left side here, this panel is that laminar flow with Anita nicely highlighted. In the absence of aortic stenosis, the valve should open wide openly there. When you replace with either the TAVR or the surgical AVR, not all this flow is going to be nice and parallel. You're going to still have some chaotic and turbulence to that. And whenever you introduce turbulence to the system, you lose efficiency. The system, nature is so wise and built into the efficiency of not only receiving but passing, and passing without any loss of energy. And when you lose energy, you're going to translate that kinetic energy to heat or to pressure. And that translates into increasing the afterload and increasing wall stress as well, and arterial stiffness propagates. Of course, if we can design a valve that can perform in its optimal temperature and pressure and gradients, we can minimize that energy loss that it develops. So how are we going to prove that? So the ideal reference standard is using 4D flow MRI is what you see here. You see a 2D cine of a coronal image there in a patient without aortic stenosis. And then superimposed to that, you have the 4D flow. What 4D flow is 3 directions of flow with time resolved. So you have ability to characterize the flow in all the 3 directions, X, Y, and Z, as well as the time resolve. Here you have a yellow line cutting through right at the proximal ascending aorta, right above the S sign, the tubular junction. You have this cross-sectional image depicting how this flow that we can see here has obviously some electricity, some vorticity, and some of this rotation. So in the absence of any disruption of that flow, you should have that flow cutting it through completely being laminar, meaning that the highest velocity is at its center. the more displaced that this flow is from its center, you can see this arrow displacing it. We're going to look at this as a systolic flow displacement, the eccentricity of that flow. As well as we're going to measure what we call the flow reversal ratio. So that's for you, I need to explain that again, as the blood moves from the ventricle through the valve into the arteries, the more eccentric it is, as it hits the artery, is going to turn around. So that's inefficiency because instead of that blood column moving away from the valve, some of it is already returning. And obviously this crosstalk between the flow into the arteries, there's going to be that pushback. So the flow reversal ratio is a measure of also vorticity. 4D flow MRI is great because it can give us a lot of those insights, but how can it be translated to day? You can't do 4D flow MRI in all the patients, let alone MRI, even more so, more difficult 4D flow. So we have to dumb it down to a 2D phase contrast and we need to do some validation. So here we are using 2D phase contrast on a normal flow on the valve. You can see, and this healthy aortic valve, you have the flow displacement that is very minimal. It fills up the column with a very low reversal ratio. And a patient that got treated with severe aortic stenosis post-AVR, post-TAVR, I should say, with similar flow displacement and flow reversal ratio. Contrast that with severe aortic stenosis. You have not only turbulence that you can appreciate with the CNA MRI, but also with the 2D phase contrast, this very eccentric jet with a high displacement and a high reversal ratio, and other commercially approved platforms, either surgical valves, self-expanding balloon expandable valves as well. So for us to test whether this was just a one-off case example that we got lucky with, we wanted to make sure that we could evaluate this systematically. This was a EMBARK study in which a subgroup of these patients received cardiac MRI first in human, as well as combining with the EFS. We had baseline and 6 months MRI, ultimately leading to a pair data, pre-post, with 39 patients. They were matched with another 35 patients, again, also age, sex, and hemodynamics adjusted. Because we know, as we unfortunately get older, the arteries get a bit stiffer. Chronic hypertension sets in, that arterial stiffness is going to set in, and that crosstalk is also going to become impaired, let alone the valve that also can have some continuous sclerosis and impairment. So now you have baseline pre-AS, fixing with the valve, contrasting with the 35 patients. What do we see? Similar age as you would expect because we attempted to match as much as possible. But we can see that post-AVR, New York Heart Association class, gets back to its normal atrial fibrillation, a little bit more on the controls and ischemic heart disease. But let's take a look at the flow properties. What happens after you fix that valve, contrasting with pre-disease state? Of course, none of these patients had aortic, none of this control had aortic stenosis, but you can see that the indexed flow reversal ratio, because we index into the aortic area, had a substantial improvement of that reversal ratio that we talked about before, similar to the matched controls, as well as the flow displacement improvement that you could see comparing to the age matched control. So the first idea that that leaflet design might be able to restore the laminar flow, we have been able to address. The question becomes in your mind is, so what? The so what becomes now, what is the impact that that ventricle is going to feel? And that seems to be associated with a LV mass regression that we can see in this pre-post AVR, matching very closely with the control matched. You can see there is improvement on the LV mass regression, improvement also on the GLS, although the numbers are relatively small, improvement on the non-invasive calculation of the wedge pressure. Left atrium also gets smaller, which is another surrogate of if the ventricle is doing better, the left atrium should get better as well, and the left atrial strain reservoir as well. So you're affecting the cardiovascular system, and also we need to look into what happens with the artery. So we addressed that first question and the physiological benefit of that into LV mass regression. So if that's the case, how can we predict? So what drives then ultimately the endpoint that we measure as LV mass regression? Is important. And we were talking about that in my comment before, ppm matters. So if you can lower the gradients, that drives 32%. And then when you add the delta and the flow reversal ratio, you also impact even more so on the LV mass regression. However, there is a synergy between not only driving the pressure down, but when you drive the pressure down, coupled with flow laminar restoration, you can increase even further the LV mass regression. And if that's your ultimate endpoint, for all the reasons that we have explained, we need not just to decrease gradients, but also to improve that flow. And our next step in this journey is trying to understand then what drives that flow restoration. And I think in a lot of that has to do also with how we can optimize even more so of not just deploying a valve, but understanding frame expansion, circularity, implant position, leaflet mobility, absence of halt. All of that is going to lead to a better laminar flow achievement to a greater number of patients. So in summary, the current AVR platform does not restore. In some patients it might, but it's not universally seen. The initial MRI results show that this appears to be possible in many patients, returning to the match controls without the disease. This meaningful ventricular remodeling is going to be also tested in the Paradigm trial, comparing Duravar with commercially approved prosthesis. And this new finding that not only reducing gradients, but also restoring the flow appears to provide even a greater synergistic effect to the endpoint of LV mass regression. Thank you so much.
Thank you, Jean, and the speakers. I think the three of you have really are forcing us again to start thinking out of the simple way we've thought about TAVR and about valve replacement. Stefan, I'm going to start with you. This whole session a little bit looks like, we're searching for the holy grail of TAVR valves, right? That one valve we can put into young patients that will be as similar as their native valve. But with all things, when I speak to people and I talk to them about these new technologies, I go, yeah, let's wait 10 years. And come back to me in 10 years when you have the durability data and show me, because we've just learned, in the last few months that even valves we thought we knew can fail at 6 to 7 years. When these last three presentations, they start talking about flow, talk about LV regression, talking about laminar flow, how do you see that as a surrogate to valve durability, and whether, do you feel comfortable talking to a young patient with this data that you may be able to give them a valve that will last longer?
So my answer is short: nothing trumps clinical long-term data. So I think we are all excited about the hypothetical underpinning of this valve technology. And I think one needs to credit the manufacturer that they really invest thoroughly in an investigation on objective evaluation using MRI, which is not easy to perform. I mean, Joa mentioned this. An MRI study is already difficult, but then for the MRI, it's a different scale. But having said this, I think you need to prove that all these hypothetical benefits also translate into clinical outcomes. And I think you need to set the bar. But I think that there are two levels. The first one is the peri-procedural safety kind of 30-day period. If you are reassured that in terms of PVL, in terms of hemodynamic outcome, you have very favorable outcomes. Obviously, there will be an uptake in clinical practice, and that also should take place. The second one, nevertheless, is you need to put the same high bar as for the other valves that are out there. And I think the FDA really demands that all the valves should have a 10-year follow-up. And I must say, the presentation earlier this morning by Philippe Piparo on the bioprosthetic valve dysfunction and the definition, what is SVD related or other related, is really important. And I think it was summarized by Pat O'Gara. We really are in a new era where we evaluate these technologies with a different angle. Now, having said this, if you ask me how likely is it that this will translate into clinical benefit, I would say the likelihood is very high. And one thing we did not discuss, but I'm interested in, is bicuspid valves and aortopathy. Obviously, if you have a very laminar physiological flow, maybe all this, evolution of aortopathy is favorable. And we should not underestimate AVR is one of the major predictors of aortic dissection. So, I think, again, that maybe is a hypothetical benefit, but certainly looking forward to this in the long run.
I have to go back to Joao, just to, I think I learned something from your lecture. Maybe you correct me if this is right or wrong. There are a lot of people who believe that gradient and flow are related. So like gradient is related to the quantity of flow, let's say it like that. So if you have like low flow, you get low gradients. If you have high flow, you get high gradients. So this is why some people do say flow gradients don't matter. But I understood that it's not only the quantity of flow, but also the quality of flow. So you can increase flow, but improve its quality and decrease gradients. Is this
Correct. Correct. Yeah, you got it absolutely right. And they are not interposed. I mean, they have, each one of them has its own meaning, and they are more than additive. They are synergistic, and achieving that is where we need to move into, and more research on how we can optimize the delivery, the prosthesis performance, so that we can make it just like the in vitro aspect.
Any ways to assess the quality of flow, like its laminarity, with other tools?
Yeah, so there has been some effort to do this through echo. There's something called particle PVI, particle velocity imaging, that you can simulate some of those path lines that we showed on the cardiac MRI. Sometimes you might need to give a little bit of some contrast. The problem is the quantification of that. And so even when we were starting to go into this field, some of the area that had contributed quite a bit was actually on the bicuspid aortic valves. And we know that bicuspids, even in the absence of stenosis, the flow is already perturbed, just of its opening itself. And so while shear stress and vorticity was already there, we are trying to translate now to a prosthesis. And that's where we borrow some of those. We don't have those same parameters being capable of measuring that by echo, just as you can imagine. How can I get that parallel orientation? You need 3D by echo. Maybe there is no 3D velocimetry that we have done by echo yet. It might come, but that might be good for industry to think.
Brian, I loved your presentation. I'm so glad we're talking about LV mass and patients who continue to have diastolic dysfunction post TAVR. A couple of questions. For the regression to occur, I mean, do you think it's just, again, a question of lower gradients, higher EOAs, or could there be other variables that lead to the regression? And how much time do we have to wait to be able to evaluate two different technologies to be able to say one is better at reducing LV mass regression? Is this a 1 year, 2 year, 3 year endpoint?
Yeah, when we looked at predictors of greater regression in that large study of 1,400 plus patients in partner with moderate or severe LVH at the beginning, we were not very successful at finding predictors of LVH regression. In that analysis, EOA gradients were not predictors of regression. So I think we have a lot to learn about the factors that drive it. Analyses that have been done that look at cardiac damage staging and whatnot, I think have provided insight into the fact that it's a very complex picture, that we see cardiac damage at moderate and mild AS as well. And I think studies also pointing to the fact that comorbidities, diabetes, renal dysfunction, obesity, et cetera, play a lot into LVH. So I think hemodynamic parameters likely play a role, but how much of it is unclear at this point. And I think so to definitively address, like, is it a valve per se? You'll have to do this in your trial and say, when you randomize them, did we see an impact on LVH regression based on which valve they are randomized to? All other factors, the same.
And Brian, can you please speak also to the measurement of LV mass by echo as well, on how that gets calculated?
Yeah, I think, echo is not the best way to, I mean, there are a lot of different formulas that one can use and a lot of pitfalls around LVH measurement on echo. And certainly the gold standard or the best is MRI or CT. And so when that's available, that's the best way to go about it. Smaller sample sizes to detect differences. So to the extent that you're getting follow-up CT, I can't remember in this protocol, maybe at a year, that could provide smaller sample size to be able to detect some differences that require larger numbers when echo is your tool of choice.
Yeah.
So I haven't seen any questions from the audience. So I guess you all understand about biomimetic valves now, and we've got you all convinced that we can here we go, restore physiological flow. Please.
Hello, thank you so much for all the presentations. I wanted to ask a question to Dr. Cavalcante about your presentation. I was very curious for the flow reverse ratio. How do you choose where to measure the plane? Do you visually assess the vortex and choose, or is a more systemic way of choosing the plane to assess, and it's throughout the whole cycle or only during systole?
So great question. So we have to pre-specify that. So that's at that same level that we measure, as well as the vorticity and the flow displacement, typically at the STJ or slightly above. We obviously have to measure above the frame. So the valve is going to be placed. We have to obviously go slightly above the frame. And we measure this throughout the cardiac cycle, because you need to measure how much it went. As systole is over, almost at the end, you start to have already a counting of how much blood flow comes back around. And you index that to obviously the aorta. Because obviously, as you can imagine, the larger the aorta, the more buffering you could allow that flow to be abnormal. And that also becomes a chicken or the egg. The more abnormal, the more you have wall shear stress, the more dilation it could occur. So we have to determine at a preset, typically above the stent frame, mid-ascending aorta, right at the PA, and then you account for the size and then throughout the entire cardiac cycle.
Well, thank you. So I think if there are no other questions, we've introduced you to this new technology with a very unique leaflet design, with really a long history of this company making tissue. So Stefan, what's next? Where do we go with this novel design that potentially restores physiological flow?
So thank you, Azim. I tried to summarize our session a little bit. And I think we all agree that we have been very privileged during the past 15 years to live through an era of strategy trials, comparing TAVR with SAVR with an unprecedented amount of evidence, 12 randomized clinical trials, over 10,000 patients with strong guideline recommendations. But this era is over, and it will be replaced by head-to-head trials directly comparing transcatheter prostheses. Now, just to set the stage, where can we improve? On the left side, you see the loss in life expectancy after surgical aortic valve replacement in the Sweetheart registry. And on the right side, you see more recent data paralleling this with transcatheter aortic valve replacement from the Swiss TAVI registry. And what you note is that there is actually a lack of normalization of life expectancy, which is most pronounced among younger patients. So if you are 50 to 60 years old, then the loss in life expectancy is in the order of 5 years. Similarly, here in the elderly population, if you look at patients 70 to 74 patients 4 years of age, still there's a loss of life expectancy of 3 years. And that begs the question, can we do better? And against this background, we have heard the previous presentations where perhaps different or additional mechanism looking at improvements of hemodynamics and restoration of physiological flow in the aorta may be additional therapeutic targets, as conventional AVR, as we perform it right now, is associated with eccentric and displaced flow in the ascending aorta. And in this context, the the Durava transcatheter system with this novel biomimetic valve affords an improved hemodynamic profile, rivaling that of self-expanding transcatheter valves. And as we have shown, as we have seen from the presentations from Anita, Brian, and Joa, it also demonstrates a restoration of physiological flow dynamics. Now, the question is, how do we thoroughly evaluate this going forward? And this shows you the clinical trial program, which is a randomized clinical trial in a basically all-comer patient population with high-risk, intermediate risk, and low-risk patients, which are randomly assigned between the Durava platform and commercially available transcatheter aortic valve systems. The primary endpoint in that randomized clinical trial is a composite of death, stroke, and cardiovascular hospitalizations. And importantly, patients will be followed annually through 10 years. As part of this randomized clinical trial, there are predefined CT and MRI substudies specifically aiming at the questions we discussed before. And second important pillar is that of failed surgical bioprosthetic valves, when valve-in-valve procedure using the Durava platform will be performed. Here, the primary endpoint is the same: death, stroke, and cardiovascular hospitalization, and patients will be followed throughout 5 years. And finally, there's a continued access low-risk randomized cohort restricted to low-risk patients. Again, randomly assigned between Durava and commercially available ads. And here the primary endpoint is at 2 years. And the entire cohort for low-risk patients will be derived from partially this all-comer cohort and the continued access low-risk cohort. And in summary, Paradigm distinguishes itself from other head-to-head trials that it not only compares a biomimetic valve against commercially available TAVR options with a clinical endpoint trial, but it really assesses the impact using high-resolution CT and an MRI imaging to study the impact on myocardial structure and function, as well as aortic flow patterns. And finally, it really provides some comprehensive assessment in patients at any risk level. It also investigates a valve cohort, so you have clinical information across the entire spectrum of risk. I'm closing to raise your appetite in case you have not learned enough in this session, just to make you aware that there will be a live case session tomorrow morning. There will be another session in the afternoon detailing the balloon expandable TAVR system by Rishi Puri. And finally, in the afternoon, Joa will dwell more in the mechanistic insights. I'm closing here. Thank you very much for your attention.
Thank you. Thank you, everyone, for joining our symposium. Hopefully, you learned about a new novel technology and its potential to restore physiological flow. Enjoy the rest of your meeting.